me.
Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
Hello, friends. Welcome to the Senior Rehab Podcast. Thank you for the download. Thank you for your time today. I am very excited for you to meet today's guest, Jessica Schwartz. She is a physical therapist and so much more, but I'm going to let her tell you about that. Jessica, welcome to the show.
Thank you for having me, Dustin. How are you doing today?
Better than I deserve, Jessica. I hear that a lot from my patients, so I've kind of adopted that saying. So this is the second or third time we've talked. I'm really impressed with you and your career, but I don't know where to start. So when people ask you, what do you do? How do you answer that question?
Oh, golly. I always say I'm a physical therapist first, and then everything else kind of derives from that. And I think that's just so neat that we can represent ourselves as physical therapists or as physios, like the rest of the world calls us. And then I kind of go from there, and I kind of tailor the conversation to where I need to fit in. So I like the fact that, physios were able to adapt to essentially any area in medicine or health and wellness that we need to. And that's what's so great about the profession is you can adapt your interests, through your career. So you don't have to, quote unquote, stay in orthopedics or in neuro or in geriatrics. It's just neat that we have that ability to kind of adapt to whatever our needs are. So right now, I say that I specialize in concussion, and that's my my today role. And it's so neat because concussion covers all of the systems, all of the bases. So I've got to be up to speed on my cardiovascular, autonomics, neuro and ortho, and some cognitive behavioral training as well. So it keeps me busy for sure.
Yeah. How did you end up in this area of interest? I mean, is this something you set out to do long ago, or do you have a windy path that has led you to where you are today?
Yeah, I've got some crazy windy path. I think that we all envision. We go into PT school, and I was like, oh, I love kids, and I love sport. I was an exercise science major at Ithaca College and did a coaching minor in pre-med. I was a spin instructor. Got my NSCA certified strength and conditioning specialist degree. Was a personal trainer and went into physical therapy school. So I envisioned I'd be working with healthy populations and, in sport. I had a coaching minor. I love sport. I coached basketball at a JV level. I was a head coach when I was 21 at Ithaca. That's where I thought I was going to go. And then I, hit the doctorate up 2006. And, I have to say, I've kind of always lived this like imposter syndrome, and we know this happens in females more than males. But I'm like, I don't know if I feel qualified to be called doctor yet. And I think that's such a huge responsibility we have educationally and to the community and to, our communities that we live around and also the medical community. So I actually, just by happenstance, was, essentially told my last year of DPT school that I had to go to a job fair at NYU, and I just so happened to be. It was the first year they were doing orthopedic residency over at NYU, and it was a perfect timing situation. So I ended up going into residency. We were the first year in 2010, so I had a fantastic experience there, and then kind of everything set off from there.
Wow. So your main focus is head injury, concussion nowadays. So
nowadays, yeah.
as you've dove into this world, for you personally, what have been some of the biggest surprises in terms of things you weren't aware of, whether good or bad? But just what caught you off guard when you dove head first into this head injury world?
Well, that's a great question, and I've got to say, my experiences, I essentially had a dream job during residency, and then I stayed there after residency in New Jersey. And, we had a one-on-one time with the patients. I had excellent support staff, a wonderfully emotionally intelligent, motivated clinicians around me. So it was, the type of thing where you go to work and you just want to become better. What can
That's
I do
awesome.
to improve a skill set today, whether it be communication or customer service or, an orthopedic skill, manual therapy wise, things like that. So we kind of came there and we actually started a concussion program because we noticed a need. And it was like, very Dunning-Kruger-esque. You don't know what you don't know until,
Mm.
until you know. So, I think we've had these cognitive blind spots, and this is in all of medicine. So not just in physio. But
Yeah.
yeah, we started a program and, we did our best to make it as evidence-based as possible in 2010, 2011-ish. And I started seeing these concussion patients coming in, and a lot of them were pediatric. And I'm like, oh man, these persistent symptom kids, like what's going on? And it was just so unfortunate because a lot of them I had to let go because of an insurance reason. We had like 3 months with
Mm.
them and a certain number of visits. But I just knew that there was more there. But it was very, very rewarding work. And it actually brought me back to the desk willingly. Like I wanted to go and learn more. And it just so happened, October 3rd, 2013, I got hit by a car, motor vehicle.
Wow.
Yeah, yeah. Motor vehicle accident in New York City on 12th Street and 5th Avenue, an unlicensed driver doing who knows what, young kid. And, I got whacked in the back of my car at a red light. Wasn't looking, didn't see it, didn't see it coming. I was at the red light for a while. And that's kind of where my journey started and, my advocacy for this. I ended up doing 10 to 14 hours a week of rehab for a year. And I kind
Oh
of
my gosh.
lived through it all. So I kind of identified those gaps in concussion health in healthcare. And I just said, if I can never practice again in my life, I'm going to make a change here in the global architecture of medicine. So doing it
Wow.
day by day and trucking along.
That's incredible. I wasn't aware of that incident, which is, that is not a good thing, but I know lots of good things have come from that experience. So let me ask you these two questions. So based on, your experience as a patient, but then now also, as a provider and, working with these types of patients. So what are we doing well? And then what are we doing poorly?
Solid question. Multiple podcasts needed. Well, I'll jump off with maybe a 30-second or less. I think the first thing we need to
Mhm.
think of for all of our patients, and especially with our geriatric patients that this podcast is geared to, but really this is from all, for pediatric to geriatric. There are essentially
Mhm.
5 questions that Louis Gifford created, and then Adrian Lowe, therapeutic neuroscience education guru, kind of have adapted to chronic pain patients. And I think this is such a correlate to our concussion patients because essentially what we've been doing is mismanaging these patients the last 5 to 10 years and definitely
Mhm.
100 years, last century, more so than we've been managing them well. And I think we're
Wow.
just starting to start the conversation of managing these patients well and what it takes. And it takes that multidisciplinary team approach, that rehabilitative team approach, I should really say. So
Yeah.
there's 5 questions. I'm not sure if you've covered this on your podcast before, but that essentially every patient wants to know. And I think we have to start there. And I think it's just
Mhm.
a humble place as a clinician to walk in every single day, no matter how stressed you are at home, what kind of traffic you hit going in. I was always that person that like couldn't open the front door with the key and I get coffee all over myself in the morning. So
Amen to that.
yeah, right. So I'm always a little bit of a nerdy klutz there. So we've got 5. So the patient wants to know what is wrong with me. How
Mm.
long will it take? What can I, the patient, do for it? What can you, so what can we, the provider, do for it? And how much does it cost, essentially, is what Dr. Lowe has added, which I think is a great addition because those are financial stressors in an injury are very realistic.
Right.
And I think we don't do that well at all for concussion
Yeah.
patients because this isn't a black and white, pathophysiological tissue healing type injury. We have a surgical incision. We're knowing, certain injuries take 6 to 8 weeks to heal with a healthy, normal physiological environment. We know things take longer in geriatric patients. We know things take longer in smokers and obese patients and diabetic patients. But we don't really have these numbers
Mm.
and this definitive language. And when you have an injury that affects a person's being, um, you know, we just it's a horrible situation to be for both a patient and provider when things go awry and these patients become a persistent post-concussive syndrome patient. But the good news is, I have to stress this, is that 80+% of these folks tend to heal, uh, you know, well, clinically, I should say, in
Yeah.
about a month to 3 months. We're seeing really solid outcomes for most people. But I like to talk about the folks that have been mismanaged and then becoming that persistent. So that's kind of where my wheelhouse is, and I stick there.
Yeah. I love those questions. I mean, man, those are, I mean, any patient that we work with, would benefit from us asking those questions. So I'm glad you brought that up. I have heard that before, and I should do its own podcast on those five questions. So I want to ask you, just let's, take those five questions in mind.
Mhm.
Let's go back to your experience as a patient.
Sure.
In the perfect world, after you had your incident,
Mhm.
what would your care look like
Whew.
if our system was perfect? What would you want to see?
Wow, that's a
And I
great
and I
question.
asked that question because um, I think for me and a lot of listeners, we haven't worked in this world. We are very unfamiliar with it, even though we interact with lots of patients that may, be considered to have some type of head injury. But just I think our perception of what can we do as PTs, or what can physicians do, or what can this team do for a patient that has a head injury, could be vague. So just kind of paint the picture for us in this perfect world of what you would like to see in terms of care.
Wow. So, I know that the majority of your listeners are physios. But I really do encourage that multidisciplinary rehabilitative team approach. But when you break that sentence down, we really have to think of physical therapists and physios as being leaders here in this rehabilitative team.
Mm,
And, we have direct access in the United States, in all 50 states. We can say that with confidence. Now, what that means in each individual state, that's different. And I know there's the individual fight that's still going on. And, I encourage my brothers and sisters all day long, to do that fight. It's the fight that I sincerely don't want to do. And I'm so glad that people want to show up and advocate for us, on Capitol Hill and things like that. And I can support those folks, the best I can through words and encouragement, and maybe supplying some caffeine or something like that. Um, but I really want to encourage the physical therapist, in all realms. But I think it's spot on with our geriatric population. We have to consider ourselves and step into the role of almost like a care manager.
mm.
So, that's my challenge. And maybe that's going to be my challenge for 2017, that I might have just, invented it right here.
All
Um,
right.
but,
We'll make a hashtag after the show.
right, PT care manager, right?
Right.
But, who better? We're seeing these patients, if we're talking about a home care situation, we're seeing them between 2 and 3 times a week. We're physically in their homes. And you know what? Newsflash, it may not be dementia. Just
Mm,
because someone is 65 and above, 75, 80, 85. And, I have got folks that have been, working up until a year or two before their head injury, and their mild traumatic brain injury and concussion, because those definitions present day are synonymous with each other. That may change. But right now, a concussion is a mild traumatic brain injury.
mm,
And, you know, why not have a skilled healthcare provider with a doctoral level education who's affordable, accessible, advocating for these patients? Who better to, talk about, any skin changes? Um, you know, we know symptoms of an MTBI are cognitive impairment, fatigue, vestibular disequilibrium, a sleep-wake cycle disruption,
mm,
psychiatric or behavioral changes, headaches, vision and hearing changes. And then we also get indirect effects like pulmonary deconditioning, pneumonia, and so on and so forth. So why on earth would you not want a physical therapist who's in the home, who's a skilled provider, communicating with a physician and or any other, cognitive behavioral health provider like a neuropsychologist or a psychologist, and so on.
Yeah.
So, that's my challenge to physical therapists. I think from my perspective, from my injury, I was really cared for very well. I have to tell you. But
Hmm.
I will say that actually, and, shout out to our brothers and sisters on the other end, my occupational therapist was essentially my care manager. She was my advocate. Um, and, big shout out to her. Um, but she
That's
essentially,
awesome.
coordinated and saw the big picture. I think we get so honed in on our day-to-day patient care, but she really stepped back from herself and looked at that 30,000-foot view. And there's no reason that, a physio or an OT can't step up in that role, and facilitate that communication.
Mm.
So, so yeah.
Preach it. I like that. So I think that that's a good transition into something that I'm very impressed with, in terms of your work, is your interaction with so many different healthcare professionals. I mean, just across the board, you are collaborating with these different disciplines to, help better serve our patients. So I just want to get your perspective on that, because that's not necessarily common. We have a lot of I guess turf wars and whatnot, and we're I don't know, you can get the general culture that we're trying to become autonomous practitioners in the sense of, we don't need anyone else to do our care. I know that is not the meaning of a lot of people that are pushing for autonomy, but I'm just saying, married to a physician, it can be perceived as such. So I would love to hear your perspective of just your role in kind of that interdisciplinary team, and just some of the lessons learned along the way in working with other types of people.
I think especially if you're kind of quote unquote raised in that hospital environment, where the physician is, end all be all in decision making. I think
Mhm.
as we kind of have developed and we have younger physicians coming through the system, who are essentially just open to conversation and suggestions. And Dr. Lorelei Lingard, out of Canada, talks about the role of collective competence in healthcare.
Mhm.
And she essentially, she studied language. She was a rhetorician, and essentially, the theoretical framework that she developed from her dissertation and her work. She's done TED Talks. We can put some links up into the show notes for you, because I think every
Mhm.
single clinician needs to listen to this, whether a physio or a physician and everything in between. But we know that individual competence does not equal good healthcare. So I'm going to say that
Mm.
again because I believe in spaced
Preach it.
repetition when I teach. But individual competence does not equate to good healthcare. And so there's this balance between individual and collective competence. And man, do we see it in the geriatric population, because they're managed by, two, three, four different specialists, and maybe a PCP. So what we're seeing is these patients are actually falling through the cracks, and actually not getting great health care because these clinicians may not be communicating with each other. There may be a polypharmacy issue. We know that our patients on more than four prescriptions with polypharm have a 15%
Mm.
increase in falls after each medication added after that. So
Gosh.
I don't know about you, but my patients were, taking 7, 8, 9, 10 plus pills.
Yeah.
PO a day. So so I think once you kind of can be comfortable that no one clinician, physician, physio, anything in between, can care for the patient of today well.
Mhm.
This is not the one doc in a box that we used to have 100 years ago, maybe even 50 years ago. And a lot of our geriatric patients lived in that, one physician world.
Right.
And that's what they trust. They want to quote unquote talk to the doctor. But I really make sure when I, use language when I'm teaching and in person, I make sure to call the physician a physician, and I am a doctor of physical therapy.
Mm.
So I've become comfortable with that title, as I've had the experience, and I've worked hard for my knowledge base. Um, so I think the more and more we can collaborate and just kind of facilitate conversations with each other, and I've used social media, I think, well in that area. It just
Yeah.
simply becomes a conversation. Here's what I can do, here's what you can do, and here's what we can mutually do for the patient together. And I think that's a beautiful thing.
That is. So, what advice, practical advice, would you give someone listening that is kind of in their own silo in terms of a little interaction with other people that are also caring for their patient? What would you say to them to help improve interdisciplinary communication, respect, and just effectiveness as a team?
You're talking about in person, like in the clinic?
Yeah, like let's say it's someone in the clinic or home health, just whatever PT setting, just a staff clinician that's seeing patients that is hearing you talk and thinking, man, amazing, I want to be like her. What do I do?
Oh man. Well, I really believe in this FOMED movement. So it's a hashtag FOMED, and the emergency medicine physicians like knock this out of the park. They've done it so well that they've created like a 2,000 plus person conference based off of social media and critical care. So it's called
Wow.
SMAC, and they've been doing it for like 3 or 4 years now. And this all started from like two guys having a beer in Ireland, I think it was, and just kind of talking about the stuff that kind of ticks them off in healthcare, and their realm was emergency medicine. Um, so I really believe in the FOMED movement. So, access, you don't have to be in a major institution. There's so many free open access medical education things out there for you, from blogs to podcasts. Start to follow folks like yourself. You know, John Childs, Timothy Flynn, these guys and gals out there, Karen Litzy, Pelvic Guru, depending on whatever your interest is. And then just start to follow them and then become a voyeur. If you're a new hire, you don't want to walk into a new environment and kind of beat your chest and say like, I've arrived.
Yeah.
Right? So you're not going to get too far with that mindset. But just sit and watch and see what other folks that you admire do well. Jeff Moore is another, stellar example out there on Twitter and doing his thing, and see what you do well and see kind of where you fit in. And here's the thing, you may not want to step out and there and be a loud voice, but you may just want to be a voyeur. And, social media essentially is the pulse of what's going on in healthcare out there right now. And that's
a good point.
Yeah, we can have these communications and conversations in real time with folks all over the world. So to not take advantage of that, I think, is a disservice, to your own education and to our patients, because you can kind of really get the pulse of what's going on out there. So I think that's where I would start. And then you kind of see where your wave takes you. It may be a podcast like you, it may be a blog, or creating a medical education program like myself. And I'll tell you, like 90% of my faculty, they're on social media, and that's how I've kind of formed those relationships, over the years.
Yeah. And that group that you've gathered is quite the crew. Tell us more about that Evidence in Motion program, because I'm just looking at this lineup, and my goodness, like it is so impressive, and just a wide variety of people that are kind of at the top of their game. So yeah, tell us more about what you're doing with that.
Oh, thanks, Dustin. So I got to tell you, I've got 16 to 18 folks on my faculty that are just all stars. But here's what's so, and if I could, they're just like unicorns. I've got really bright clinicians who are emotionally intelligent enough to know we don't have all the answers. But here's what we do, what I'm physically doing in the clinic. Here's what my rationale for it is. And then essentially I put together this program. It's the world's first, what I believe to be at least, the world's first post-professional, year-long, and multidisciplinary concussion education program for clinicians, for everyone from the physician to the physio. And I've got to say, I'm just so proud of it. And if I had to walk away from my career once this thing, got up and running, and we have our first graduating class coming up this month, I'd be completely satisfied with that, just because I know that this is something that is accessible to clinicians all around the world. 90% of it's done online, but it's interactive. It's not like a plug and play type thing and someone walks away from it. I program direct it.
Wow.
And you've got 38 weeks of didactic education, and a 1 weekend intensive, and you have 52 weeks to complete. And the goal is to set the post-professional learner up for success clinically. This is not, a educational resource that says, okay, here's the data. We still don't have enough data to do anything with these patients, and then close up shop. This is the data that we have. This is what you can do with these patients tomorrow, because folks are just lost. And the goal is to facilitate a better managed patient in the concussion realm, from acute to chronic and pediatric to geriatric. So I've just got the coolest folks around, and oh man, it's just amazing. It really exceeded my own expectations.
Yeah, I mean, it's impressive. And I think too, just going through this list, I see, all these different types of people able to really answer those 5 questions well, or to teach, people that go through this course how to ask those questions well and how to get those answers. And I think it's really exciting. Just to see your work in this. And one thing that I do want to bring up that I think I've been thinking more about is just how past experiences inform and influence, just who you are as a person. I think about, just that terrible accident you had in New York City, where you were rear-ended, had a head injury, had to go through all that therapy. I mean, who would be a better person to create a program to serve that type of patient? I mean, you've been in the thick of it, and that's absolutely amazing. Which you did not perceive that at the time, that very difficult time. But it's so cool to see that now, and it makes me think of another senior rehab podcast guest, Joe Daniels. He's currently a student, but he lived with his grandparents and watched his grandmother take care of his grandfather towards the end of his life. And he was right there witnessing it, seeing all the struggles, all the victories, and just a part of that experience. And that has influenced him tremendously in becoming, an all-star physical therapist, going for his GCS and residency and all this stuff. So awesome. I don't know. I just wanted to bring that up because I think it's just really cool to be able to connect those dots from the really crappy times to things like this, where you're just having a big impact. So kudos to you for making it happen.
I appreciate that.
Yeah, so I wanted to transition a little bit. I'm selfishly going to ask this question. I'm a big fan of Will Smith. Okay. I grew up with him, Fresh Prince of Bel-Air. He was my boy. Him and DJ Jazzy Jeff, were in my CD player. I think from the age of, I'm not going to give age, but it was probably a decade that I listened to their album straight. So when Will Smith's movie Concussion came out. And just kind of, the past couple of years, especially in the NFL, a lot of contact sports, it's become a big issue, and the media has definitely played into that. I want your perspective on that. How has that impacted your work, potential funding, and just kind of the public perception? What's your take on that whole situation?
That's a really solid question, and I'm so glad that you asked it. We have this hypervigilance going on out there, and part and parcel it's from the fueled by the media. But here's the thing: I totally respect the media, so we need the media to get this information out. And I respect our researchers. We need them. We need them. We need them. We need them. But at the end of the day, we're producing so much research out there that you just can't keep up with it. And so what's meaningful, what's not meaningful, what was done well? Are we going to argue for 20 minutes about, the design of a study? I personally ain't nobody got time for that. It's just, it's like, oh, come on now. So at the end of the day, in all seriousness here, we have this old problem and this increased awareness. So we have to kind of, care for this conversation in the media with, kit gloves, because essentially what we don't want to happen is we don't want folks like, my generation with young kids and things like that, ripping kids out of sport, and having them sit on the couch all day, because we know that about a third of our population in the US and also in the UK. I was just fortunate enough to be on the BBC radio the other day, a couple weeks ago. Nice. So I had to use my UK. I had to look up some UK data, so I know. So about a third in the UK and the US of kids are actually obese or overweight, and that's a crazy, nutty,
Wow.
issue, because if we think of these folks getting older, they're just going to have so many more issues. And we already know that stroke is up in young patients. And what does this mean from a sequelae issue for when we become older?
Mm.
So we want to encourage safe movement, and that comes with education and a firm voice and guidance. And again, who better than a physio out there, accessible, affordable, to kind of push this information out ethically? And you have to be knowledgeable of this. This is all post-professional education you have to do. Um, and, okay, so what happened with the movie? The movie came out in December 2015. I was very fortunate enough to be invited to the movie premiere in Boston. So I
Awesome.
got to meet the author. It was just awesome.
That's cool.
And, I actually got to sit in the movie theater with professional football players and their wives, which was a bit disturbing because we had like people like audibly weeping in the middle of this movie, because they're just
Oh,
thinking
wow.
of what their spouse, male or female, could potentially be going through. So I think
Mm.
from that aspect, I think that's real, and we have to care for that conversation very carefully, and guide them and be a force in education of here's what I can do, here's how I can help you, and so on and so forth. Now, from a global population standpoint, that's not getting repetitive head injuries, 5, 10, 20 to 30 times a day for the 20 to 30 years of their lives. I think we really have to, reassure them that they're going to be okay.
Mm.
And, essentially guide them to if there are any neurological sequelae or cognitive or behavioral sequelae, we can guide them to assistance there.
Yeah.
But essentially, they have been seeing links with um, concussion, MTBI, repetitive head injuries, and similar like proteins that are laid down with Alzheimer's, dementia, and Parkinson's and things like that.
Mm.
So we do know that if you get hit in the head, and I call that an RHI, repetitive head injury.
Yeah.
So I don't want someone to think they get one concussion and then they have to be um, super vigilant and, drive themselves nuts, essentially thinking of something going to happen. But we also want to increase awareness of like, hey, what is a concussion? Like, have you seen stars? Yeah, that's actually a concussion.
Mm.
So most folks don't know what a concussion is. They blow it off and they say, oh, it'll get better. And then they kind of go on their way from there. But we really need to make sure that we know there's a correlate with changed brain volumes, gray and white matter in MMA athletes and boxers. The AAN put a statement out a couple years ago that there is no correlate with a 448 person study out of the Mayo Clinic. So we really don't know right now, but we're seeing more and more small study correlates of, hey, we're seeing decreased hippocampal volume, which is essentially who we are, where our memories are formed. We're seeing Parkinsonian-like uh, injuries and Parkinsonian, and I say Parkinsonian-like because they're not Parkinson's.
Right.
After repetitive head injury. So again, you don't want your kid getting hit in the head 20 times a day for, from the age 5 to 18, then go play a college sport, then go potentially play a professional sport, because it just doesn't make any sense. So there have been
Yeah.
changes in terms of in the last just year of no heading in soccer over under the age of 13 and 14,
Mm.
depending on where you are. You can start doing some learning how to use the skill in practice, but we don't need to do that over and over again.
Yeah.
So yeah, I think there's this balance of vigilance and hypervigilance, and there has to be something in between, and it really depends on the patient that's coming in there. Um,
That's a
so,
good point.
so yeah.
Yeah. I love I mean, this issue fascinates me, and I'll tell a quick story because I will never forget this. I was an athletic training major in undergrad, and it was my first rotation, sophomore year. I was the football. I was with the offensive line with the football team. Scared to death, I was, as an athletic trainer, I remember for me, my biggest fear was head injuries or fractures. Like if I saw someone go down the field, your heart rate goes up immediately, to around 120 beats per minute. Or for me, I was just very stressed out. And I will never forget spring practice. We offense and defense were on the same field. They were going through some different plays, and the safety absolutely drilled this wide receiver that went up for a pass. The safety falls down, and he was down for about 2 or 3 seconds. And me and the head athletic trainer, took that first step, waiting to get called onto the field.
Oh my God.
And so the safety gets up, stumbling around, and he has no clue where he is. And he runs over to the offensive huddle. And the offensive players, he was like listening for the next play. And the quarterback was like, "What? No, what are you doing?" and just kind of shove him out of the huddle. And then the player doesn't, and this is the thing that people need to realize that aren't familiar with the situation. The incentives, these players are not incentivized to come off the field.
Mm-hmm.
So this safety goes back to the defensive huddle, and he's going to play the next play.
Yep.
And the coaches didn't really notice it. They were, talking, about the next play, but the head athletic trainer did. Goes out, grabs a kid's face mask, which, may or may not have been a good idea, and pulls him off because he had to, because the player, was not going to come off the field. And that head athletic trainer had to have an argument with the head coach to get that player off the field. And so that right there really opened up my eyes to, just how many of these repetitive head injuries that are happening that are not reported, because like for that player, it could have been a college scholarship that was on the line or playing time. Then you go up to where millions of dollars are at stake. Heck yeah, I'm going to take, I'm not going to report a concussion if I've got millions of dollars on the line. So it's just a really, complex issue that, I don't have the grasp of, but it's just really, really fascinating to me when I think of the incentives.
Well, 2 points from that awesome story that just says so much. But one, we have athletic trainers rightfully actually taking players' helmets away, so they cannot go back in the huddle just like that. Just take the helmet away. And Katie Harris is a Cornell women's athletic trainer for the Cornell women's hockey team. Awesome hockey team. She'll just take a player's helmet. She's like, boom, bye. You're not going back in. So, awesome. So that's kind of the firmness and aggressiveness, because the thing we have to keep in mind, the theme, is when in doubt, sit them out. Remove, recognize, and remove. We can make up any kind of, catchy tunes to get people to consider it. But we have to recognize and remove, and when in doubt, sit them out. If you're not sure, but you saw the player get clocked, that's important to, and that's also for the geriatric population with falls. Something you don't have to get hit in the head to get a concussion, falling on your butt, and that reverberation up your spine from coccyx to head, that counts too. And the other thing is, and this is something that I came up with when I was concussed, is that the number one most annoying question that I got asked doing so much therapy and everything day in and day out, how do you feel? My grandma would call me, my mom would call me, everyone's calling me. How you doing, Jess? How do you feel? I had no idea. Yeah. Every 5 minutes was different. I felt dizzy. I felt nauseous. I felt a migrainous pain, and my eyeballs hurt. My face hurt. I had pressure in my head. The list goes on. So I say that traumatic brain injury and concussion patients do not have the subjective language to express the what and how they are feeling.
That's a good point.
So, and I say that again, concussion patients do not have the subjective language to express the what and how they are feeling. So there's two things that happen in medicine when we don't know what's going on, at least historically. If as clinicians, as doctors of physical therapy, as physicians, and everyone in between, if we don't know what's going on with the patient, two trajectories they often travel down. One, we tell them they're malingering, or two, we refer them to psych. And we've seen this with chronic pain patients. We've seen this with women and cardiovascular, like myocardial infarctions with heart attacks. Oh, it's just a little anxiety, it's just this. Nope. Women just present differently for a heart attack. Going to get that jawline pain, going to get that shoulder blade pain. Your chest may not hurt.
That's a good point.
So we've done this consistently, and then if we really don't know, we send them to psych, and just the patient assumes that we think they're crazy. So we need to get away from that, and you need to be so good here's what happens is that the concussion patient, unlike an oncology patient, a cancer patient, has infinite ports of access to care. Okay. Geriatric
Mm.
fall can go to urgent care, can go to the ED, and so on and so forth. So we need to be so good that if you're going to have a walk-in patient for a concussion come into your clinic, you better be so good with your comprehensive targeted physical examination for a concussion that you can comfortably say, I got this. If you
Mm.
can't say that here and out, looking at autonomic system, neurological systems, orthopedic screens, cognitive behavioral screening to make sure you get that patient to the right provider during the right time, then you should have no business in this world. And I say that, and that's where the Dunning-Kruger approach comes in. We have to know what we're looking at so we know what we're looking for. And
Yeah.
that's where these patients have gotten mismanaged. And I say that in a very, motivating and kind way. But sometimes we have our cognitive blind spots in medicine and we don't realize that there's so much more to the picture. And the bottom line is that concussion is a rehabilitative injury. I say it again. Concussion is a
That's a good point.
rehabilitative injury. And who better to treat these folks? But you've got to have post-professional training. And that's the bottom line. 2015 was the first formal didactic year that neurology residencies, brain physicians, had training in concussion and TBI. 2015. So,
Unreal.
right. So if that doesn't fire you up and get you motivated to go learn something, I don't know what does.
Yeah.
Um,
My gosh.
so
Wow, that's unreal. When you brought that last point up, so I think I'm going to plug the Evidence in Motion program after that for sure. That's a very good point because, and I think the people that are listening to this podcast, people like me in home health, skilled nursing facilities, or even in acute care or outpatient, just all the different settings. Like we do have to be on point. What comes to mind is that patient that absolutely scares me to death every time I knock on the door because I know she's going to get up
mhm.
and walk and potentially fall. And the patients that say, "Oh yeah, I fell last night. I'm doing okay though," and something had is probably going on. And I do need to be able to screen and appropriately refer and appropriately treat. So I appreciate you giving those words of wisdom. So I do want to be respectful of your time.
Sure.
We'll transition into some quick questions. Your responses do not have to be quick by any means. So the first one, all right, this could be a personal or professional answer.
Sure.
What would you tell your 25-year-old self?
Aha. Okay. My 25-year-old self.
And give us an idea of where you were at that time.
Oh man, where was I at 25? That's a good question. Yeah, I guess I was in PT school. Yeah, I was in physical therapy school.
Nice.
Yep, that's right. So my 25-year-old self, I would say listen and observe deeply. So listen deeply and observe deeply. And just keep your excitement. I have the same vigor and excitement, if not more today than my 25-year-old self, to be honest.
Yeah.
You know, that you had at 25. And just watch the folks that you perceive as to be great. And learn from there. And listen, I really mean this wholeheartedly. It doesn't have to be a physical therapist. There are tremendous physical therapists to observe and emulate out there. But look at other things as well. Like I go into Starbucks and a well-run small business, and
Mm-hmm.
I pick up those tacit cues that people have with customer service and listening to the patient, listening to the customer.
That's a good point.
And we have to do better for our patients in healthcare in terms of customer service. And that right there in itself, you don't have to be like the greatest clinician around, but if you can listen deeply, observe clinicians and your patients, if your patient feels a connection to you and a rapport with you, you're going to hit, things out of the ballpark that, the person with the most evidence-based research clinical targeted exam process can have. If you can't connect with your patient, then, bye-bye. See you later.
Jerry Durham and David Reed would probably kiss you on the cheek right now if they could. Saying that.
I'll make sure to give him a high five and a chest bump when I see him at CSM.
Okay. All right. So next question, your favorite continuing education. I know I want to, put the plug in for the Evidence in Motion program that you lead. You've mentioned the FOAMed. Any other courses or resources come to mind that have really helped you in your work?
Yeah, sure. I'll talk about concussion specific. Like, listen, I'm like an individual provider. I pay for all my own stuff, and I'm all about free. And if we can kind of compare to the vestibular world, like, get everything out there in terms of what you can get for free, and that's pretty well done. So, speaking from that, and that's what FOAMed means, by the way. So free open access medical education, #FOAMed. So the CDC, the Center for Disease Control, has wonderful free open access information. Not only do they have free open access stuff for you, but they have stuff you can print out, put it on the computer, slap your own logo on it, and you get pretty good information. So,
wow.
Here's the thing. Folks have a processing issue when they have a head injury. Simple bottom line. So someone like myself that likes to talk all day long, folks maybe remember 5 to 10% of what I'm saying. So you really need to make sure you space repetition this out with your patients in terms of the information you're providing to them. A, it's a lot. B, they're overwhelmed. And C, they've got a head injury. So you've got to get so good and concise. So the CDC has not only pamphlets, but they have videos and other information for yourself as a provider and for your patients. So it's a really great place to just kind of get your feet wet. When you kind of have that information down, I recommend going over to Home Base. MGH and Harvard and the Department of Defense have this wonderful grant. And Dr. Grant Iverson is a neuropsychologist out of Harvard and MGH. And he runs a 4-week free open access course on concussion. It's awesome. Really great resources, things like that. And it's free. And they offer it quarterly. Yeah. And there's a great physio actually as a part of the program, which just means they're just way cutting edge and getting it. Lenore Hergert, and she does a wonderful job in that. So there's that.
And I'll link to that in the show notes.
Bingo. Sure. Yeah, we'll make sure to get that out to your folks. And then kind of when you have that, you take that information and space rep it out, listen to it in your car, listen to podcasts and things like that. Then I really truly, recommend coming over to EIM. It's an investment. You're looking at an investment in your future, but what you're getting is you're surrounding yourself by a network of skilled clinicians. From your faculty members to myself who have access to the answers and questions you have, because you're going to realize that you're going to have questions with your patients that you're seeing in front of you. And I make it clear that I'm happy to help throughout. And you can ask my graduating students now. I make sure to take the time with them to if I don't know the answer, I'm comfortable with my own self to say, I don't know, but let me do the research to help you find out. That's awesome. So that's where we kind of have to be from a humble standpoint in our clinical leadership.
Yeah, I like that. So after the continuing education, and we kind of go more into kind of the clinical standpoint, let's say you're practicing, seeing patients, what are some of your favorite tools, equipment, or resources that help you do a good job?
Well, I really like a nice backpack to take with me wherever I go. So that's number one. And what I fill,
that is huge.
Yes, what I fill in that backpack. Generally, I have my iPad or computer, and I actually use the King Devic test, which is a rapid number naming test. And that basically is looking at saccadic eye movements. And essentially what we know is that the brain, more than 50% of the brain's pathways are devoted to vision. So I say that again, more than 50% of the brain's pathways are devoted to vision. So what we know is that vision is much more than acuity, much more than 20/20. And essentially what happens is we have ocular motor impairments post-concussion and post-TBI. And we're seeing them in, tremendous numbers. And essentially that's kind of we've missed in the world of medicine. We've missed the vestibular component. We've missed the cervical spine, and we've missed the ocular motor component. And we know the vestibular and the ocular motor component are really just go hand in hand together. So when speaking to physios, and I was just in Long Beach, speaking at the California Physical Therapy Association Concussion Conference a couple weeks ago, and I basically said, and it's like Ranchos Los Amigos world out there, right? So
yeah.
so I was like, well, I got to make a correlate to what they know, and I was like, imagine your right leg and your left leg are moving in different directions, and you're trying to walk forward. Now, more than 70% of our sensory environment is perceived by vision. So if our eyes are not working together, there's something ain't right. We're not feeling well. We don't know how to subjectively explain or express what we're feeling. We know that because of what I said earlier. Concussion patients do not have the subjective language to express the what and how they're feeling. So you've got to do a really good ocular motor vision screen. So I do use the King-Devick test as well as a comprehensive full ocular motor screen. Is this in my wheelhouse? Am I comfortable with this? If not, I refer out to a vision specialist like behavioral optometry and OT that may have training in vision therapy, or a physio. Karen Scott down at the VA in Tampa is a wonderful physio with training in all of the above. And out of UPMC, Ann Muka is another like all-star physio who's actually on our CDC panel, who does really great work there as well. So I also use motion guidance tools for kinesthetic and proprioceptive awareness and positional awareness. I think it's really great stuff. It's a bunch of physios that kind of put this company together. You can work on your C-spine. You can work on kinesthetic and proprioceptive awareness with like lower extremity, upper extremity, C-spine, and the whole nine. And it comes with really great stuff. It's small, it's portable, you throw it in your bag, and it's just a good thing. And then I use like really cheap like stuff. So for most folks have visual motion sensitivity. So our environment, it's like ugly, Christmas sweater, holiday party time. So a lot of those are visually offensive by themselves. But but folks with a TBI, even more so. Going to a Mexican restaurant and tiles, I had an issue with that. Never thought of it, but I actually had oscillopsia. So stuff came off the paper and was moving around, and that's pretty petrifying. So I also work on some visual motion sensitivity with my patients. Anything from like a cheap dollar store checkerboard, YouTube videos of busy New York City streets, because that's the environment that I'm in. Patterned cloth or clothing. You can get at like a Michael's store for $1. Throw that stuff in and you can get really creative with that. Essentially, we're primed to think on how to rehabilitate TBI and concussion patients. We basically get training in moderate and severe TBI like most people do. But what's different is that these folks in MTBI and concussion are a little higher level. But at the same time, you have to include the behavioral, cognition, and the environment adaptations as well for them. So it's it's thinking more than just the 3x10, prescription, an exercise prescription or something like that. So once you can kind of adapt yourself to that, it's not that easy. Don't get me wrong. It's pretty neat. But all that stuff you can kind of bring with you in a backpack, and it's pretty stellar.
Awesome. All right, last question. My favorite one. Let's say we're at CSM. You have every geriatric rehab clinician in the room. You have their attention for a minute or so. What would you want them to know?
Ooh, all right. CSM, every geriatric clinician present. Advocate for your patient. Be their voice. Period. End of story. And you may be the only one, because you may be the only one that's in their environment, that's listening to them deeply, looking at them at that 2-foot view, that tunnel vision view that's right in front of you, but also that 30,000-foot view. Do they have folks to care for them? Do they have fiscal, issues? Do they have other cognitive behavioral issues? I say this very sincerely. It's not dementia. You have an 85-year-old female that just was a psychologist working up until last year, and she hit her head and is now, having word finding issues and sensory issues. It's not dementia. Let's make sure we get these folks screened for appropriately and into the right hands, because they may just kind of get in that mismanagement wheelhouse, because other providers, again, you have to know what you're looking for so you know what you can do for these patients. So just advocate, advocate, advocate.
I love it. I love it. And that I really appreciate you coming on to this lovely podcast, Jessica, because just sharing your story, being vulnerable, about your accident and just how that's informed your work today. I mean, that's very motivating for me. And I definitely want to encourage the listeners to think about your experiences, good or bad, and how you can take that perspective and use it for good to make some change in the world. So yeah, thanks for your time. Let me know, how could people ask you questions or interact? Or you're on Twitter, you said. What's your Twitter handle?
Sure. My Twitter handle is at DPT2go, so at DPT2go. And I also run a blog. It's been quiet, but I have my goal of producing monthly to quarterly blogs starting in 2017 again. I essentially built this 38-week program and took time off from writing, but I'm super excited to get back to that. So at www.pt2go.co. You can also go dpt2go.co as well. I bought both of them because it's confusing with my Twitter handle. Feel free to email me at jessica@pt2go.co as well. But I would say Twitter is the best way to go. Like, ask those questions, make them public knowledge, and start a conversation and let people who may be more of a voyeur learn from your questions, because I guarantee there's, if you have a question, at least 20 other folks have the same one.
That's the truth.
Get that conversation started.
Yeah. So I will link to that in the show notes, your website, email address, Twitter handle, all the resources that we mentioned, some of the studies, the TED Talks. So be sure to check out the show notes, people. Lots of good information in there. And Jessica, thank you for your time. Keep doing what you're doing.
No problem, brother. Thank you for doing what you're doing so well. Appreciate it.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you enjoyed this episode, you should hop on over to seniorrehabproject.com to find more helpful content. You can also find out how you can join the team and be a part of the private Facebook group, the monthly mastermind meetup, and have a say in the content and direction of this podcast. Once again, that's seniorrehabproject.com. I appreciate you, and I'll talk with you soon. But in the meantime, do not forget to stay funky.